Hello guys, I hope you're okay. So today we're going through ACE inhibitors, and previously we've gone through sort of ACE inhibitors and what ADRs are linked to them. So with ACE inhibitors, generally you can't give ACE inhibitors in pregnancy or breastfeeding. That's point number one. Now the logic behind this is because any drug that sort of interacts with the renin-angiotensin-aldosterone system generally will be teratogenic, or you should kind of be precautious when giving it to a breastfeeding woman or giving it to a woman that is pregnant, etc., as it may affect the fetus. Now, we've previously gone through the fact that with severe hypokalemia, you may be able to sort of give IV potassium chloride for severe hypokalemia, and that would correct the issues of hypokalemia. Now, another important point is because if a patient is not able to take oral potassium supplementation, then you can give IV potassium chloride. And that would make sense because maybe the patient is vomiting, maybe the patient cannot take something orally. So that's very, very important. Now, if we quickly look at some antibiotics quickly. So with antibiotics, there are certain antibiotics which affect sort of warfarin. So what antibiotics are these? So for example, clarithromycin, erythromycin, and doxycycline can affect the anticoagulant effect of warfarin. So that kind of means that it would affect the INR of warfarin actually. So you have to keep that in mind. Also, a very, very important point is if you have a CYP inhibitor, that means that it will reduce the INR of warfarin as well. So essentially, CYP induces reduce INR of warfarin. And that would mean CYP induces increased INR. So you have to keep that in mind when you're revising as well, because that is very, very crucial. And thank you so much.